or imagine the breast as a clock face. Now check the epitrochlear lymph nodes by palpating the groove between the biceps and triceps muscles. The nodes should not feel enlarged or tender. Throughout the assessment of the patient's arms, note their range of motion, muscle mass, and strength. To assess the vascular system in the arms, inspect the patient's hands. They should feel warm, and you should not detect edema or lesions. Next, check capillary refill time by depressing a nail bed until it blanches. Then quickly release the pressure. The nail bed should regain its normal color in 1 to 2 seconds. Palpate the radial and brachial pulses, which should be equal, regular in rate and rhythm, and strong, but not bounding in amplitude. Continue the assessment by evaluating the arm's sensory function. Follow these guidelines. Have the patient keep his eyes closed. Scatter the stimuli. Vary the pace. Compare distal and proximal areas. Compare both sides of the body. And map any areas of sensory loss.
Please close your eyes.
To assess for light touch, randomly touch a cotton wisp to the patient's arms and have him tell you when he feels the touch.
No. No. No.
To assess the patient's pain sensation, use a broken swab to test sharp and dull sensation. Tell the patient to identify the sensation as sharp or dull as you lightly touch his skin with the swab. Alternate the sharp and blunt ends of the swab.
Sharp. Dull.
If the patient has trouble identifying these stimuli, assess his temperature sensation in a similar way using test tubes of warm and cold water.
Please close your eyes.
Warm. Cold. Warm.
To test the patient's vibration sensation, activate a tuning fork and then quickly place its stem over a distal bony prominence, such as a finger. Instruct the patient to say now when the fork starts vibrating and again when it stops vibrating. Perform this test in both arms. Normally, the patient can tell when the fork starts and stops vibrating. If he can't, test his vibration sensation more proximally. You'll also perform this assessment in both legs later in your exam.
No.
Good.
Next, assess the patient's position sensation. Have the patient close his eyes.
Down.
As you move one of his fingers up and down, instruct him to tell you which direction it is moving in. He should be able to do this accurately. If he can't, test this sensation more proximally in both arms and later in both legs. Now assess the patient's touch discrimination with the next 4 tests. The first test assesses stereognosis. Ask the patient to close his eyes. Then place a coin, key, or other object in his hand and ask him to identify it. He should be able to do this correctly.
Good.
The second test assesses graphesthesia. Perform this test if the patient has difficulty moving his hands. Trace a number in the palm of his hand and ask him to identify it. He should be able to identify the number accurately. The third test assesses 2-point discrimination. Randomly touch 2 sharp objects to the patient's fingertips and then gradually decrease the distance between the 2 objects.
2.
Note the distance at which he can no longer perceive 2 separate points.
2.
Normally,
1.
this is less than 5 millimeters. The fourth test assesses extinction. Touch 2 corresponding parts of the patient's body at the same time and ask him to show you where he was touched. He should be able to feel both touches and identify their location.
There.
Now test motor function by assessing the deep tendon reflexes. For each test, have the patient relax his arms. And remember to grade the reflex on a scale of 0 if it's absent to 4 if it's hyperactive. Start by testing the biceps reflex. Place your thumb on the patient's biceps tendon and strike it with a reflex hammer. Normally, this causes the forearm to flex. Next, test the triceps reflex. As you support the patient's upper arm, strike the triceps tendon above the elbow. This should elicit forearm extension. Now test the brachioradialis reflex. Strike the forearm 2 to 3 centimeters above the radial styloid process. This normally causes forearm flexion and supination. Finally, you'll assess the cerebellar function of the arms. To assess rapid alternating movements, have the patient pat his knees with his palms facing upward first and then downward. Have him gradually increase the speed of his movements. His movements should be coordinated and equal. Next, ask him to touch his thumb to each finger on the same hand and then to reverse the direction. He should be able to do these rapid skilled movements quickly and accurately. Then assess point-to-point localization using the finger-to-finger test. Have the patient touch your finger with his finger and then touch his nose. His movements should be smooth and accurate. Also perform the finger-to-nose test. Instruct the patient to close his eyes. Then have him stretch out his arms and touch his nose with one index finger, then the other, gradually increasing the speed. Again, his movements should be smooth and accurate. Before assessing the abdomen, consider the patient's history. If he reported abdominal pain, plan to examine the painful area last. If he has a full bladder, have him void to encourage relaxation. During this part of the exam, observe the patient's face regularly for signs of pain or guarding. Start by inspecting the abdomen from the ribs to the symphysis pubis. Its contour should be symmetrical. To highlight any bulges, shine a light across the abdomen toward you. No bulges should be visible. Assess the umbilicus, which should be midline and inverted. Next, auscultate the abdomen. Always auscultate the abdomen before percussing and palpating it, because these actions can make bowel sounds more active than normal. Begin by placing the stethoscope's diaphragm lightly on the right lower quadrant. Because the ileocecal valve is in this quadrant, bowel sounds are usually audible here. Listen for at least 2 minutes. Assess bowel sounds in all 4 quadrants. Determine if the sounds are normal, hyperactive, hypoactive, or absent. Be sure to listen for 5 minutes before concluding that they're absent. Now auscultate for vascular sounds by switching to the bell of the stethoscope and listening over the aorta, renal arteries, iliac arteries, and femoral arteries. Listen for bruits, which may be heard during systole. Bruits are abnormal. Next, percuss in a systematic fashion. You should hear dullness over the solid organs and tympany over the air-filled organs. You may also hear dullness over a distended bladder, adipose tissue, fluid collection, or a mass. You may hear hyperresonance over a gas-distended organ. Now percuss each organ, beginning with the liver. To assess the liver, percuss from the right lung area down the midclavicular line until you hear dullness. Mark this point, which is the upper border of the liver. It's usually located at the 5th intercostal space. Then percuss up the midclavicular line from the umbilical level until you hear dullness. Mark this point too, which indicates the liver's lower border. It should be at the right costal margin. Measure the distance between the 2 marks to estimate the size of the liver, which should be 6 to 12 centimeters. Now assess the stomach by percussing over the left upper quadrant. Percussion here should produce tympany. Next, have the patient roll onto his right side. Assess his spleen by percussing from the 6th rib down the mid-axillary line. Expect to hear dullness between the 9th and 11th intercostal spaces. Now percuss at the lowest intercostal space in the anterior axillary line, where you should hear tympany. Then ask the patient to take a deep breath and percuss again. You should still hear tympany. If you suspect the patient has a urinary problem, percuss the bladder. Start at a point 5 centimeters above the symphysis pubis and continue to percuss downward. you should hear tympany over an empty bladder or dullness over a